Myrna and I are going to do this sort of back and forth in the spirit of partnership and thinking about what we might say at the end of a panel in 12 minutes. It's been a little bit of a challenge, I have to admit. And I think so many of the comments that have already been made, some of the themes that go through them are themes that would be common to our project as well. So we're going to try to move along here. I do want to give a little bit of background to the project, but a tiny bit, because we want to focus mostly on the process issues. And what I will say is that the project that we're going to be situating our comments within was funded by CIHR in 2012. It's a 5-year grant that was funded as part of these projects for looking at programmatic grants looking at health and health equity. And unlike the projects here that are community-based, where the focus is very much on the ground working with people in their health, this actually has an organizational tilt. So our interest in this project tries to address the question, here we go, tries to address the question of how is it that we could actually strengthen primary health care services so that they pay better attention to equity? And what difference would that actually make on the ground for people who are living in more marginalized conditions? So that's really the focus of the project. In a nutshell, these are the 3 purposes. It's programmatic, so 3 things. One objective, we're testing an organizational intervention within these clinic settings, so those are our partners, that's trying to promote equity-oriented healthcare practices and policies. We have some work that is focusing on developing different sets of indicators for tracking equity, and another piece that's trying to analyze the policy and funding context. But most of what we're going to talk about is situated within that first project. And I'm actually going to skip over a couple of these slides because I do want to get to this one, which is who the partners are. So it's a study that's actually being undertaken in 2 provinces, an academic health sector partnership study. The 2 leads are the University of British Columbia. Dr. Annette Browne is the nominated PI. She's from the School of Nursing at UBC, and Western in London, but other academic organizations. And then a number of policy partners who aren't on the slide, including the Public Health Agency of Canada. And most importantly, the real key partners in this are the 4 primary healthcare clinics that we're working with, 2 in British Columbia and 2 in Ontario. And this is a participatory project, participatory rollout and evaluation of an organizational change. And so what's important about the clinics is that they all, each one of them, serve people living in marginalized conditions, and each one of them has a mandate toward equity, but they look very different from one another. So they're different types of models of care, they're funded differently, they serve different populations, and they're in different contexts. Some are in urban settings, some in rural settings. It's quite a wide range. And the project is as much about trying to implement change within these organizations as it is about to learn from their best practices. Because there's already, we knew coming into this, there was a lot of good things happening in these organizations, and we really are interested in also capitalizing on a rich description of what that is, thinking about how that could be rolled out. So the organizational intervention essentially is 2 parts. It's a 12-month intervention with the staff in the organizations, a piece that's around education that focuses on principles of equity-oriented care, Indigenous cultural safety using an online platform developed in BC but adapted for Ontario for our sites, and trauma and violence-informed care. And that's followed up by a 6-month organizational change where the organization and the staff go through a process of looking at what their strengths and weaknesses are relative to some of the things that we've dealt with in the first part, and going through a change process that they identify, and of course we track the changes through that. And we're evaluating it in a variety of ways, which wouldn't be surprising, but one of the things I'll point to is that we are doing interviews with a cohort of patients within each of these settings 4 times over the course of the project. And I just want to make note of that because Myrna is going to be speaking about some of the negotiation around how those interviews have taken place. So I think I will turn it over to Myrna, who's going to talk a little bit about one of our clinics, the Health Zone Nurse Practitioner-Led Clinic.
Hi. So I'm a nurse practitioner in an NP-led clinic, and we are fairly new. We started officially in 2011, but really didn't have our grand opening to 2013. So the clients that we are seeing, purposely we went forward trying to address the needs of women and their families who are marginalized, who have had trauma in their lives. And our clinic is unique in that we have 3 clinic sites, 2 of them co-located in low-income housing units. We are literally one of the townhouses is within those units. And the 3rd site is in a family crisis center. And then we do outreach as well. So we do outreach to women's shelters, a family shelter, and a day program for street-involved women. So we really do sort of draw from that group. So we came into this project really being excited, thinking that this would help our staff develop. We're a small staff. We have 4 NPs, 2 RNs, a social worker, a dietitian, and 1 position for a physician consult that's currently being shared by 3 physicians. So small. We thought we had a lens towards equity, but we had a lot to learn. So it's been interesting, that journey.
Pictures up.
Oh, my picture's up. So this is one of our sites. This is Marymount site, which is that co-location idea. As we began this EQUIP journey, we really started to look at team meetings, large team meetings, and the team meeting of the researcher also included the clinical leads from some of these other organizations. So I myself was on the research team as well. Interesting. Gave me a perspective of other people, what they're doing. Also gave us, in one of these opportunities, a trip to Vancouver to actually look at a clinic that had a very similar mandate but is now 20 years old. So how has that evolved from a clinic that is only 18 months old? So it was a good way of looking at it. We also had to really work with our staff to identify clients that had used us enough to qualify for Marilyn's study, because really we were new and we were looking at people that had at least had 3 separate contacts. And for us, people in shelter didn't always meet those needs. Sometimes we had to look at the day program because they were a more steady group that we were actually interacting with on a weekly basis. So when we got around to the point of really looking at client interviews, we had other challenges and other concerns. And one of them really was around space. We have very small space to allow for private interviews. We had to really work hard with our staff to encourage people to share their trust with interviewers. And I think that speaks to some of what you were saying about finding the right people to do the interviews. And technology. So a lot of this was tablet-based. Many of our clients are not literate in their own language, may not be literate in English as well. So we had to really work with the interviewers to set those priorities around that and help people feel comfortable in that situation. But overall, although we had lots of concerns, it went extremely well, I was happy to say. And we did provide, well, the study provided incentives for clients too. And I know that some of our staff had huge concerns about people leaving with money, and would they be accosted or would they have safety issues because we're literally right within their home situations. None of that happened. So whether we were just lucky, I don't know. We also tried very strategically to plan interview days around times of the year. So many of our families, they're single parents. We couldn't interview or have an hour-long interview if the children were around, so not doing it during March break, trying to center times in the middle of the day when the children were at school, or making allowances to have infants in arms in interviews as well. It was a bit of a challenge for the interviewers, but it worked all right. And sadly, we also targeted not check day. So we knew that we wouldn't have good intake on days that social assistance checks were going out. So those were some of the things we faced.
Myrna, would you like to just talk a minute about the staff engagement? I think that might actually be helpful, so that the issues around the new team and the...
Well, the new team, yes, that was certainly part of it. Trying to have recruitment of people that understood our philosophy. We thought we had a pretty good recruitment that way. The interesting part for me also was sitting on the research team and hearing some of the researchers discuss engagement. Part of the tasks that we did was an online cultural safety module. I didn't learn until afterwards that if you got a phone call, it was because you were a red flag on the cultural safety. So that was kind of difficult to hear as also an administrative lead person, realizing that one of your staff clearly wasn't engaging in the way that we thought that they were. So it was interesting. The other thing that's been interesting was the provocation of emotions with some of that. So doing both the trauma-informed care workshops, doing some of the cultural safety, and actually looking at that vicarious trauma piece really brought it home to us. As a new staff, they were probably not as prepared as we thought they were for the types of clients and the complexity of the issues that they were facing on a day-to-day basis.
And I think we're just about done, so I think I'll just put up this last slide, and I think maybe this summarizes some of what everybody else has already said, but we think in this study and in many of these studies that effective partnerships, you know, it's really all about the relationships that you have, or at least in large part about the relationships. And some of the ideas that we've heard already are around the shared values and agenda. You know, part of the reason this project works is because although we're very different, we live different realities, the busy clinical setting versus the researcher versus the client who's coming in for care, we all have the same agenda. The trust and respect, expecting challenges and having a process for working through it, the negotiation around the issues that are important so that things fit. You know, it's not a standardized approach. And we heard flexibility and mechanisms for being able to have ongoing communication, whatever that ends up looking like. And if you're interested in the study more, we have a website, equiphealthcare.ca, and there's lots of information up there. Thank you.